Hi everyone, Dr. Najeeb here. Today we are going to talk about a very important part of anatomy, that is a golden segment of femoral artery. Golden segment of femoral artery. Why a specific segment of femoral artery is called golden area or golden segment? Because that is extremely important clinically, and also if you don't know that segment very well and its relationship, you may fall into very serious clinical traps, right? So let me tell you what is that segment. As we know that basically aorta divided into common iliac arteries, and then here I am showing the right common iliac, and it will divide into internal and external iliac. Now this external iliac artery, while it is passing through the pelvis, right, just under the inguinal ligament, it will enter into lower limb or it will enter into thigh, right? Now this area, I will come over this diagram, it is more illustrative. So we can see this is external iliac artery, which is basically present in pelvis. Here is inguinal ligament. The moment external iliac artery passes under the inguinal ligament, right, it is leaving the abdomen and pelvis and it is entering into lower limb. Here it changes its name from external iliac artery to femoral artery. Now, the part of the femoral artery which is considered the golden part, that is basically extending from just below the, what is this, inguinal ligament, and just above the profunda femoris, and just before the, from here up to here, that where this artery up to here, where this segment in lower part divides into its superficial part and deep part, and deep branch is called profunda femoris. Now, question is that why this segment is so important? Why I'm stressing it so much? The reason being that we can find palpatory findings over here, right? We can have auscultatory findings over here. We can use this segment to take sample for arterial blood gases. We can use this segment, golden segment, which is extending from the, yes, extending from the lower part of inguinal ligament up to before, what is that? Origin of profunda femoris. So it can be used for palpation, where it can, you can know the rate of the pulse or rhythm of the pulse or character or quality of the pulse, or even you can determine radial delay or radiofemoral delay. Not only palpatory findings, sometimes you will find here auscultatory findings. These things I will discuss later. And same segment is also used for compression. Why we use it compression? If someone has severe trauma in lower limb and person is bleeding profusely, if person is bleeding heavily and you want to reduce the bleeding in the lower limb, right, then what you can do, you can compress this golden segment. Wow, what makes it golden? One reason it is golden is that just behind it, if you compress this artery, right, it will not be pushed back too much, because there are very serious and firm structures behind it. Let's suppose this is femoral artery. If you press from here, this will be pressed against, what is this? Tendon of psoas, and here is your acetabulum having the head of the femur. So basically, when you press this artery, you are producing a compression which will be between your fingers or thumb and between the head of the femur. It is more clear over here that if you are pressing over here, right, it is going like that. So what are the main structures? That if person is profusely bleeding, you need to compress an artery in the lower limb so that from lower limb bleeding is reduced, maybe due to roadside accident or industrial accident or gunshot injury or any reason, right? This is life-saving information, that femoral artery should be compressed in a special golden area. It should be compressed below the inguinal ligament, but above the profunda femoris, and against the, you will press it posteriorly against the, this artery will be pressed against the psoas major or pectineus, and especially the head of the femur. To be very specific, usually it is medial third of the head of the femur, which is present over here, right? So the beauty of this segment is that it provides a backstopper, that when you compress it, right, you will reduce the blood flow to the branches, both branches. You will reduce, you are compressing over here, so you are reducing the blood flow to the superficial branch, and also you are reducing the blood flow to the deeper branch, which is profunda femoris, and that will significantly reduce the blood flow and hemorrhage or bleeding from the lower limb. Of course, a life-saving technique. Now, question is that when you are going to, I told you there are many uses of it, as I told that it is used for palpatory findings. Remember, thumb should not be used. I will tell you later, right? Actually, you use these fingers. What is this? Index, middle finger, or max ring finger. You can use them like that, but never use thumb, right? Why we don't use thumb? Okay, let me tell you. The reason being, even though intuitively you can think that because this is a firm artery and large caliber artery, so a thumb is able to produce more pressure, more firm pressure, but there is a tragedy. You know, thumb has its own arterial blood supply, which is relatively strong. Artery, digital artery in the thumb is principus pollicis. Principe pollicis. This is quite strong. So when you press with the thumb, sometimes clinician may become aware of his own pulsations in his thumb. So he will not be able to properly sense the patient's femoral pulsations. So don't use thumb. Now question is that if it can be used for so many purposes, not only the purposes I told you, that pulsations, auscultations and compression, it can also be used for taking sampling, cannulation. For example, you have to take sample of arterial blood gases, you take sample, or cardiologist, interventional cardiologist, they use very commonly, even though now in many circumstances they prefer radial, but still it is very important point that they use interventional cardiologist, they use femoral artery to access the cardiovascular system. They puncture the femoral artery in this golden area. Later on I will explain in detail that if you go above the golden area or below the golden area or laterally or medially, what tragedies can occur. There is a trap waiting up. There is a trap, clinical trap below. There is a clinical trap if you move too medially or too laterally. I will discuss. Right now what I want to say that this segment of femoral artery, right, it is extremely important, used for pulsations detection, or used for auscultatory purposes, used for compression in case of profuse bleeding from lower limb, used for you can say sampling of the arterial blood for ABGs, arterial blood gases, can be used by the radiologist and also by cardiologist, right? Now, these interventional cardiologists can use to puncture this part of the vessel artery to get access to the cardiovascular system, where through the puncture they move retrograde and they can go. How? They can go into pelvis, into common external iliac artery. From here catheter enter and common iliac artery, external iliac artery, common iliac artery, aorta. Even they can go to, on the way, the other arteries will also come, like renal branches and mesenteric branches. But if they want to reach up to the heart, they can take the catheter all the way up and negotiate up to through the arch of aorta, into root of aorta, and even to the left ventricle. Right? So what does it mean? That this segment, this special segment, right, this can be used, okay, I will make it very clear, this segment from here up to here, right? Now this segment, if you cannulate through it and you catheterize through it, right, then you can go for many endovascular procedures and cardiac procedures. For example, if you have to deal with some kind of angiography, renal angiography or angioplasty, or you go more above, you can go for coronary angiography, coronary angioplasty. You can go for some other procedures in left ventricle, some valvular diseases like stenosis of mitral, for example, aortic stenosis, you can deal with that. So this is domain of the interventional cardiologist. What is intervention cardiology? Intervention cardiology is that part of cardiac specialty in which we use catheters for diagnostic or therapeutic purposes to deal with the structural lesions of cardiovascular system. Interventional cardiology is a branch of cardiology where we use catheters, right? And these catheters can help us to produce angiographies, right? They can help us to many diagnostic procedures and even therapeutic procedures, like angiography coronary is diagnostic, and if angioplasty or stent placement, this is therapeutic, right? Now, it means this segment is extremely important. Before I go into further detail, I want to tell you one thing, that you don't, because there are many procedures are done there, even sometimes if you want to do continuous blood pressure monitoring in a patient who is critically ill or patient who has cardiovascular collapse, and you want to take minute to minute, rather moment to moment blood pressure reading, you cannot deal with the blood pressure apparatus with cuff, right? Then we also put a special catheter here which is having blood pressure sensors, and you get a continuous reading of blood pressure, and you know if blood pressure start falling, immediately you will give the vasopressor drug, right? So this segment is extremely important, right? I will repeat it last time, what things it can be used. It can be used for clinically for palpatory findings and auscultatory findings. The next lecture will be only on this thing, that what are the palpatory and auscultatory findings, right, which can be clinically picked from the femoral artery. But other things what we can do compression in severe hemorrhage, we can do in this area cannulation for arterial blood gases, we can do catheterization, and that can be invasive catheterization, minimally invasive you can say procedure, which can help us in many diagnostic and therapeutic purposes in cardiovascular system, right? But the primary question is how you find this part of femoral artery. How you find this part of femoral artery, because if you move a little medially, you are puncturing the vein. If you move a little laterally, you are puncturing the nerve, damaging the nerve. If you move a little above, you are in the pelvis. You are puncturing basically external iliac. And if that starts bleeding, that may bleed very heavily in the retroperitoneal area, and hematoma will not be visible, and patient may go into, you can say, internal bleeding and eventually into shock. So there are traps. If you move little medially, you are injuring the vein. If you move little laterally, you are injuring the femoral nerve. If you, unfortunately, you puncture the artery too high, you are damaging the external iliac artery or inferior epigastric artery, and you are risking the retroperitoneal hemorrhage, which can be sometimes life-threatening. Then, if you are too down, then you are not puncturing the golden segment. If you are too down, you may puncture the branches, either superficial branch, right, which is apparently continuation of the femoral artery, or you puncture the profunda femoris, and these punctures produce lot of complications which I will be discussing, right. So there are so many traps around this area. I will discuss every trap in detail, but first we should know that how to find exactly in a given patient where is femoral artery and how to palpate it, right. Ideally, you should have ultrasound arrangement, but of course it is not everywhere. So you just don't go blindly. You will use the special mapping of surface area in this area. Actually, if you really want to find the femoral artery, I will make here, okay, we can come here. This is pubic bone, right, and this is both pubic bone meeting in the midline, right, pubic symphysis. Now, and this is anterior superior iliac spine. Now, if point number 1 is, star number 1 is a star point, star 1 is anterior superior iliac spine, right, here. Second, when you go to the, come into dead center of pelvis anteriorly, you are actually pubic symphysis. We put it star number 2. Now, from star 1 to star 2, what I mean, from anterior superior iliac spine up to pubic symphysis, let's take this distance. Let's take this distance from here, right, up to here. So this distance is, yes, this distance, first of all, you should measure. So what you need to do, you ask the patient, positioning, flatly lie on the bed in a spine, of course in spine position. When patient is lying in the spine position, right, now you have to find these 2 points and you have to reach to the femoral triangle where this golden segment of femoral artery is located. Now, especially in obese patients or highly muscular patient, to make the access to this artery more easy, you need to relax the fascia lata. You know, fascia lata is anterior to this artery, right? Fascia lata is the deep fascia of the thigh. Now, to relax the fascia lata, what you do? Number 1, patient is lying spine, you take this limb, for example, right, if operator is dealing with the right limb, it will be slightly abducted, taken out, and then toes are rotated, right? It means there is abduction, slight abduction with slight lateral rotation. Actually, this maneuver makes the fascia in upper thigh relax, right? It is no more compressing strongly the artery, it makes it relax so that your finger can easily go deeper. And not only this, actually it also makes the borders of triangle more clear, right? You know, femoral triangle borders are what? Superiorly, the border, femoral triangle border is superiorly inguinal ligament, and if you look laterally, it is the medial part of sartorius, and if you look medially, it is a medial border of adductor longus, right? So this triangle here is inguinal ligament, here is sartorius going, and here is adductor longus medial part, because remember many times students make confused, they make lateral part of adductor longus. No, it is medial part. And when you talk about sartorius, sartorius also medial part, and here is inguinal. Now this area in between, right, this area from here, yes, here and this is your femoral triangle. So to make the femoral triangle, what did you do it to make it easy to palpate there and find the femoral artery pulsations? Patient was lying supine, and relevant lower limb, if you are dealing suppose with the right, you will make it, especially in obese people and very muscular people, you will slightly abduct and then rotate the toes outward for some lateral rotation, so that tissues in this area become lax, especially fascia lata, and muscles become more prominent. So what happens, that femoral triangle is more visible. So this is the basic positioning. Now after that, how to find this artery, right? I was telling you that for that purpose, you have to find two bony landmark. Number one is anterior superior iliac spine. Number two, exactly dead middle of, yes, interior part of pelvis, that is pubic symphysis. Now, if you draw an imaginary line in between these two, right, just in the center of this line, just center of this line, right, just center of this line and just below the inguinal ligament, if you press, you are pressing on femoral artery. So how to localize femoral artery, because you have to do many procedures there and many clinical, you can say, maneuvers there. So one way, the best way is patient lying supine, involved limb slightly abducted, slightly lateral rotated, and find the anterior superior iliac spine and pubic symphysis, and this imaginary line, find the exact center of that, and at that center, just below the inguinal ligament, of course you will palpate the presence of inguinal ligament. Don't go for inguinal crease, I'm saying inguinal ligament. Inguinal crease and inguinal ligament are somewhat different. So you palpate the inguinal ligament, you palpate these two fixed bony points, come to the dead center of these two bony points, and just below or inferior to the inguinal ligament, you press with, yes, don't tell me thumb, no, press with your index finger, middle finger, and if needed, ring finger. You press backward, but ideal is these two fingers, index finger and middle finger. You press it backward. The beauty of this site is that there is a backstopper. There is a backstopper. What is backstopper? That behind this, there is if you press it here, this artery will be pressed against, you can say, a psoas major tendon, which is not very compressible, and of course very hard. What is this? Head of the femur. So artery will be through this psoas major tendon or sometimes a part of pectineus, lateral part of pectineus, artery is compressed again through these structures, compressed against the head of the femur, and then it will you can feel its pulsations, because when it is compressed, it will bound anteriorly, right? Because it cannot force this according to the pulses. So you will feel the pulses in the finger pads of index finger and middle finger, right? And once you feel it, it is like this. Once you feel it, right, you have to be very careful. Don't go above the inguinal ligament. So this is the way that you localize the golden area or golden segment of femoral artery, right? Now, once I must tell, what is the name of this point? The name of this point where you are compressing, this is called mid-inguinal point. So what is mid-inguinal point? Mid-inguinal point is this one, right? Mid-inguinal point. That it is in the inguinal region from interior iliac spine. Again, I will repeat. What is mid-inguinal point and what is its clinical importance? Mid-inguinal point is in the center of imaginary line, which you can imagine extending laterally from the anterior superior iliac spine and medially to the pubic symphysis, and center of that is mid-inguinal point. And if you press, this is very important point, because if you can locate this point just at this point just below the inguinal ligament, if you compress, you should be able to find the femoral artery pulsations. Is it clear? This is how you localize. But there is one confusion. I want to make it clear. The confusion is that there is another similar name which is called, yes, that is not mid-inguinal point, that is midpoint of inguinal ligament. This is different. Midpoint of inguinal ligament is different and its clinical relevance is different. And student, because phonetically they look similar, so very commonly innocent student confuse them. So I will like to help you to differentiate these. First of all, mid-inguinal point, what is it? It is the exactly midpoint between the anterior superior iliac spine and the pubic symphysis, and when you press at this point just below the inguinal ligament, you are able to localize which artery? Femoral artery, right? Now, what is this midpoint of inguinal ligament? Midpoint of inguinal ligament is actually point which is between which is middle of the inguinal ligament. Now, how to find it? Lateral point is same, where inguinal ligament is attached. Laterally, you go for this point, mid-inguinal point, or you look for midpoint of inguinal ligament. You take the same bony landmark, that is anterior superior iliac spine. But when you are looking for medial point, actually from the midpoint you move laterally and you will find elevation or tubercle on the pubic bone, which is off center, and this tubercle is actually star 3, we can say it, right? Now this is pubic tubercle. What we do, if we imagine a line between anterior superior iliac spine and pubic tubercle, right, and draw the exact center of this line, not the upper line. Now you see, upper line is longer because it is going up to the symphysis. Both of them, lateral edges same, anterior superior iliac spine. But medially, the line which you draw or imagine for mid-inguinal point goes up to symphysis, pubic symphysis. But when you look for midpoint of inguinal ligament, laterally it starts from the same place, anterior superior iliac spine, but medially it is attached not in the center, rather it is at off center point, which is little lateral, right? That is pubic tubercle. Now, so this line, because its medial end, its medial anchor is little lateral, so its center also, center of this line also become little lateral. This point is called midpoint of inguinal ligament. It is exactly center of the ligament itself. This is the center of the ligament itself. So midpoint of inguinal ligament. So here is midpoint of inguinal ligament. So we can see the mid-inguinal point is slightly medially and midpoint of inguinal ligament is slightly laterally. But this slight difference makes huge difference clinically. Why? Because midpoint of inguinal ligament is basically help us to localize femoral artery. But when we talk about midpoint of inguinal ligament, as lateral bony anchor moves little laterally, so naturally midpoint also moves a little lateral, and when it becomes a little lateral, right, if you come vertically, it is coming to what? Femoral nerve. It means it is not going to femoral artery. If by any wrong chance, if you are too innocent a medical person and you forget it was you want to puncture for to take a sample for arterial blood gases, very common procedure. If you are puncturing or you are going to push your needle right into arterial blood flow and you forget, first of all, never do it blindly. There are so many clinical traps around this area. Number two, remember that you have to puncture just below the inguinal ligament at mid-inguinal point, which is slightly medial to the midpoint of inguinal ligament, right? But unfortunately, if you forget and you just find mid-inguinal point, which is between the anterior superior iliac spine and pubic tubercle, which is off center, and at this point, if you put your needle, actually, number one, less sad thing is you will not get arterial blood. Very sad thing is you will puncture or hurt the femoral nerve, and that will basically patient will feel severe pain. And if you try it repeatedly at that point to get the arterial blood, my God, you are doing something very dangerous. You are hurting your patient for long term. Not only patient is having severe pain right now because you are pushing your syringe in the nerve, femoral nerve, rather if it is damaged, that will lead to long term burning pain or paresthesias in the thigh and through the saphenous nerve, even medial side of the leg, sensory disturbances, even motor disturbances, which will damage femoral nerve so much that femoral nerve is the major motor supply to the quadriceps muscles, right, which extend the knee. And if those fibers are damaged, patient will eventually develop weakness, and then along with that, patient will develop the, you can say, weakness in the muscles or even atrophy of these muscles, quadriceps, and there will be loss of patellar reflex, and patient will have difficulty in standing from the sitting position. Even sometimes patient get so much injured that they find it difficult to walk because quadriceps are not keeping this leg extended during the walk, and leg will buckle under their weight, and especially for climbing they have troubles. So why such a terrible thing happened? Only due to simple mistake that our innocent doctor, which is no more innocent now, did not remember that when he is going to deal with the artery, He has to find the mid-inguinal point, not the midpoint of inguinal ligament. Now, as I told you, mid-inguinal point, clinical importance is localization of artery just below the inguinal ligament. But midpoint of inguinal ligament, this point can be used when you want to anesthetize very carefully. But usually even for anesthesia around this femoral nerve, usually we need this when there is severe injury or severe pain in the lower limb of fractures, or you are doing some orthopedic procedure, you want to give regional anesthesia. In that case, even in that case, first you are supposed to localize what? Femoral artery. First you localize femoral artery and then inject your local anesthetic slightly laterally, because in this case artery is acting as a what? Anatomical landmark, right? Even if you are going to give the, what is this? Femoral block, right? You are going to inject the local anesthetic around the femoral nerve, so that if patient has undergoing some, patient had severe fractures in lower limb, or you are going to do some operative procedure or orthopedic procedure in lower limb, and you intend to give the regional femoral anesthesia, please first localize this artery. Now question is that if we have to anesthetize the nerve, of course don't inject inside the nerve, you around that, right? But the thing is, why we localize the artery? For two purposes. Number one, when you localize the artery, you know nerve is lateral. Number two, you may not inject inadvertently local anesthetic in the artery, because if local anesthetic in high dose is given into systemic circulation, that can lead to severe problem in the heart, cardiac arrhythmias, and even it can produce seizures. We will not discuss that into detail, but I just wanted to print on your mind the importance of difference between mid-inguinal point, which is for femoral artery localization, and midpoint of inguinal ligament, where just below the inguinal ligament, femoral artery is entering into upper thigh or femoral triangle. But there is one more importance of this point. Okay, I will make this point more clear. This point, it has one more importance. The importance is, one importance I told you, just below the inguinal ligament, what we have? Femoral nerve. Just above the inguinal ligament, here there is, yes, here there is a weak point. Good surgeons know what is it. It is internal inguinal or deep inguinal ring. What is this? Deep inguinal ring, just above the, not just above the inguinal ligament, about 1.25 centimeter or so, depending upon the build of the person, right? So there should be some distance here, okay? What is this? Deep inguinal ring, right? So if you are looking for hernia examination and you want to find the deep inguinal ring, sometimes we are doing hernia examination, we want to find exactly where is that point, so we can reduce the hernia and then compress that and ask the patient to cuff so that we can feel hernia reappears or not. That I will teach you in detail in hernias lecture, upcoming hernias lecture. Right now you just trust what I'm saying, right? What I'm saying, that midpoint of inguinal ligament, which is a little lateral to the mid-inguinal point, this point has two clinical importances. Number one, just a little above, or 1.25 centimeter above the inguinal ligament, there is deep inguinal ring, through which in males suprametic cord passes and in female round ligament passes, and of course if there is internal inguinal, you can say hernia, that will also pass through it, right? Actually, I will not go into detail of hernia, but it has two importance. Number one, deep inguinal ring. Yes, deep inguinal ring. And number two, above the ligament, right? We are talking about now this point. This. I've made it here. So here what you will find, now you will tell me. Yes, deep inguinal ring. And what here you will find? Femoral nerve. So this is the line you have to be careful. If you are looking for deep inguinal ring, you will go for midpoint of inguinal ligament. But if you are looking for artery localization, you will go for mid-inguinal point, right? And the difference is that mid-inguinal point is little medial, right? And midpoint of inguinal ligament is little lateral. This little difference is a great difference, right? This was which point? Yes. What was this point? Mid-inguinal point. And what was this point? Midpoint of inguinal ligament. The difference is not so much, right? Their names are even somewhat confusing and similar. If in today's lecture only you remember this thing, what is midpoint of inguinal ligament and what is mid-inguinal point and what are their clinical importance, right? That's great. Now, in next segment, I will continue. Up to now, we just discussed about what is golden area or segment for the femoral artery. We discussed about these two midpoints, these two confusing midpoints, right? Please go and discuss this with your friends. Make it clear to them also, right? And in that process, you will revise your own information. Then you have we talk about patient positioning and eventually localization of the artery, and I also told what are the purposes of localizing this golden segment of common femoral artery. That you find pulsations, or you can look for here for auscultatory findings in some pathological conditions, or you can compress it in case of profusely, heavily hemorrhaging lower limb, right? Compress it against the, remember, head of the femur, and then you can use it for arterial blood gas sampling, or you can use this localization for different radiological or interventional cardiology related procedures, different endovascular procedures. Even you can put a catheter here for continuous what? Blood pressure monitoring, right? Here we stop. In next segment of the lecture, I will discuss that what is the exact technique, how you put the needle there, and I will discuss about the clinical traps, that if needle is put too medially, what will happen? Don't tell only that it will puncture the vein. The real doctor knows that if it punctures the vein, then what happens? If it too lateral, if punctures the nerve, then what happens? And good doctor should know if you are too above and you puncture the external iliac artery or inferior epigastric artery, then what will happen? Or if you puncture too low, you puncture the superficial femoral artery, which is the continuation of femoral artery, or profunda femoris, right, or try to catheterization here. Good doctor should know what will happen, what could be the complications and how to detect them. But the best is that you should stay for your cannulation purpose or femoral artery access purpose within the golden segment, which is at mid-inguinal point, just below the inguinal ligament, extend, and it extend not beyond where artery bifurcate, and medial and lateral structures are also very important. Medially it is having vein, and laterally it is having nerve. One thing you need to remember, that femoral sheath, I'm going to draw the femoral sheath, right? Now femoral sheath is basically fascia transversalis coming from anterior abdominal wall, fascia iliaca from the posterior abdominal wall, and when artery, vein and lymphatic system moves from abdominal cavity to the lower limb, a sleeve of this fascia comes along with that, right? Anterior part of fascia is, what is this? Fascia transversalis. And posterior part is, what is this? Fascia iliaca. Both of them fuse on the sides and make a sheath. So this sheath is here. This is fascia iliaca and this is fascia transversalis. Through artery, vein and lymphatic system is passing through that. But you need to remember, nerve is outside the sheath laterally. Nerve is outside the sheath laterally. It means that nerve is basically present over here. This is nerve, right? This is femoral nerve. It gives branches as soon as it enters. And what is this? This is up, this is external iliac, and below, what is it? Femoral artery golden segment, right? And medially, what is here? Yes, femoral vein, maybe here the saphenous vein come, but here is which vein going? External iliac vein. And this is lymphatic channel. There is a special lymph node here. We call it, this is actually, this part is called femoral canal. It is just some loose areolar tissue, lymphatic vessels, and there is a special lymph node here which called lymph node of Cloquet, right? This lymph node of Cloquet is very important. It drains many structures, but for a little fun, it drains the clitoris. Of course, in female, and in males, it drains the glans penis, not whole penis. But it drains other things also. Will not talk in this lecture at this moment. But just I want to say, the femoral sheath consists of, it is just like a sleeve which is coming from abdomen posterior to the inguinal ligament, dragging down into upper part of femoral triangle, and it contains femoral artery, femoral vein and femoral canal, right? And nerve is outside this. What's the importance of this sheath? It is very important, you know. All the time you are moving your hips, hip joint, and these vessels, there is an inguinal ligament here which act as a binding strap to keep this neurovascular bundle not to stand out, right? But these arteries and veins slightly glide up and down. So they glide within the sleeve. So sleeve act as a, you can say, lubricating and facilitating the movement which you might make thousands of the time every day, right? So the sleeve moves little bit up and down, and artery, vein and lymphatics are there, but nerve is kept out. Why the nerve is kept out? Thanks God it is not within. Why? Because artery is pulsating about 72 times per minute. These pulsations will hammer the nerve 70, 80 times per minute and you will have trouble, right? So thanks God, nerve is kept out of this beautiful sleeve. Of course, we'll have a full lecture on this sleeve also, and femoral canal, femoral hernia. But right now, we'll stop our lecture here, and in next segment, I will go into detail what is the best way to make puncture here, right? Femoral artery access and puncture. And what if you don't do it well, what complications will appear if you go too much above or below or lateral or medial, right? Thank you very much. Right, this is the part 2 of the lecture. We were discussing in previous lecture that in part 1 that femoral artery localization and why it is so important, right? And in which procedures localization of femoral artery is done. And we also discussed that what are the surface anatomy landmarks to localize the femoral artery, common femoral artery. Now, and we also discussed that this part of the femoral artery, which is starting just below the inguinal ligament and before the bifurcation, this segment, this is the golden segment of the femoral artery, or this area is the golden area. Why this area is golden area? As I mentioned previously, because whenever you are making puncture, right, either you are doing it for arterial blood gas analysis or you are going to do some catheterization or any procedure, if you have to make a puncture in common femoral artery, this should be where, what we discussed last time, at mid-inguinal point, just below the inguinal ligament and above the bifurcation of common femoral artery into superficial femoral artery and profunda femoris artery. So this is the area which is the golden segment where we should feel the pulsations or auscultate, or you can say we want to make arterial blood sampling for arterial blood gas analysis, or we have to do cannulation here, or we have to pass the catheters here during some endovascular procedure or during interventional cardiology procedures. Now, question is that why this segment is so important, right? We will discuss now specifically two things. Number one, why this segment is considered so important, and secondly, we will discuss that if we don't puncture at the right segment, at the right place, right? For example, if puncture is too high or too low or too medial or too lateral, what complications can occur? This is the topic of this part of lecture. So first of all, we come back. Why this part of the artery is selected, right, for different procedures? Number one, it is wide caliber or large caliber artery, number one. Due to this reason, if you are passing catheters or procedural cannulas, basically that will not injure endothelial lining significantly. If artery is narrow, then endothelial lining will be damaged significantly, or even when you are passing the catheters, smaller arteries may be occluded, right? So number one, it is wide caliber, right? Number one. Number two, it is superficial, very superficial, just under the skin and facial layers, right? What you really find in this femoral triangle, where the femoral artery is there, anterior to it there is skin, superficial fascia, and then fascia lata. So it is so superficial, easy to approach. So it is wide bore, it is very superficial. Then another thing, that it is relatively fixed, right? And that makes the procedures in this artery through this artery relatively easy. Why it is relatively fixed? Because it is the part of the femoral sheath. It is within the femoral sheath, as I discussed previously, that if this is the, okay, we can see it here, this is femoral sheath, right? And in this lateral compartment, artery is there, right? And always remember, nerve is outside and vein is medial to it. So The nerve is outside the sheath and lateral to the artery, and vein is medial to the artery. So, number 1, it is wide caliber vessel. Number 2, it is superficial vessel. Number 3, that it is relatively fixed vessel. Number 4, that post-procedural, if you need to compress mechanically or manually, it has a backdrop or backstopper of medial side of the head of femur. So you can press it against the head of the femur and reduce the bleeding from here or block the puncture point, right? So how many points? Wide bore vessel part, number 1. Number 2, very superficial. Number 3, relatively fixed. Number 4, that when you compress, there is back support to it, that is the head of the femur. Just behind it, there may be psoas tendon or lateral part of, what is this? Pectineus. And just below that, you have inferior to that, not inferior, just posterior to that, you are having head of the femur. So, and then another thing, it can directly, if you are catheterizing for cardiac procedure, it can directly go through major vessels. For example, as you know, that it will, a common femoral artery will go to the external iliac, then it will go to common iliac, then it will go to aorta, and through the arch of aorta, it will end up at the left, through the aortic valve, left ventricle. So it is relatively straight pathway. So how many reasons I discussed? It is wide bore, number 1. Number 2, it is superficial. Number 3, it is relatively fixed in the femoral sheath. Number 4, it has a back support by the medial 1/3 of the femoral head of the femur or femoral head. Number 5, easy pathway to access the cardiac left side of the heart, right? Now, we come to the clinical traps. As I discussed that this was the lecture about the femoral artery localization, basic anatomy, and clinical gems and clinical traps. Now we discuss about the clinical traps, that what are the dangerous situation here. First of all, we will discuss in 4 ways, that in this artery, let's suppose I put the artery here. This is profunda femoris branch. Now, and here is your what is it? Inguinal ligament. Now, this artery, as you know, that it is coming from external iliac artery. When it passes under the ligament, this external iliac artery convert into common femoral artery, right? From here, the common femoral artery start. Now, from here up to here is the golden segment, just at mid-inguinal point, just below the inguinal ligament, extending up to the point of bifurcation and just interior to the head of the femur, right? Medial part of the head of the femur. Now, if ideally you should puncture the artery in the center, not to medial side, not to lateral side, right? And preferably it should be vertical puncture or slightly inclined, not too much inclined, because if you make a vertical puncture, it will make a nice small hole which is easy to close post procedurally. But if you make it too much tilting, you will raise a flap and that may become difficult to close. So in this part of the artery, you will make the puncture, and when you will make the puncture to access the arterial lumen, it should be very vertical or slightly inclined, not too much inclined. This is one reason. And secondly, don't move medial or lateral, because that will injure the surrounding tissues. Now, for example, rather than here, if someone makes a mistake, ideally speaking, ideally in present day, you should not only localize it digitally, but if you should have some imaging way or ultrasound through which you can verify the position of this artery just and make it sure it is lying just in front of the head of the femur, medial third of the head of the femur. This is very important. But if you are doing it blindly, you have to be very careful. Why? Because what mistakes you can do? Number one, if you go too high, you puncture too high, or you puncture too low, or you puncture too medially, or you puncture too laterally, right? What complications will occur? We will deal one by one. First of all, if inadvertently you make the punctures too high, right? It means just above the inguinal ligament. Actually, you are puncturing where? You are puncturing external iliac artery. This is one risk. When you puncture the external iliac artery, there are some very serious issues. When you will withdraw the needle, you cannot compress it. This part can be compressed against the head of the femur, but there is no bone immediately below external iliac artery. So what happens? That if you, when you puncture here, and if this puncture point bleeds, this bleeding will accumulate into retroperitoneal area, right? So this bleeding from a puncture point which is too high, if bleeding is going into retroperitoneal area, we have multiple problems. Number one, as I told, we cannot compress it and stop it. Number two, we may not be aware of it, that patient is bleeding, because when bleeding is going in retroperitoneal area, that area can literally take liters of blood without making any significant clinical signs and symptoms until cardiovascular system is about to collapse, right? But if bleeding is occurring here, of course it is very superficial area, and that will make hematoma, and you will become very soon aware of that this puncture point is not properly sealed. So what really happens, if puncture is too high, the puncture point, if it bleeds, it will not bleed into superficial tissues. For example, if this normal puncture point bleeds, right, it will make a hematoma in just under the skin and fascia, and of course we will be very much aware of it, and very easy to press against the head of the femur and manage it, right? But if puncture point is here, multiple problems. Problem number one, that hematoma which is being formed, or bleeding or hemorrhage which is occurring, that is retroperitoneal, and it is not very obvious, and it is not making any significant pain, and large amount of blood will be bleeding there. It will be a way, you can say, concealed hemorrhage. And number two, even if you know that there is some bleeding going on there, you cannot compress it against any bone there. So what will happen? If you don't diagnose it early, and most of the time it is very difficult to diagnose early, it keep on bleeding there, patient is just talking to you, everything apparently looks fine, and suddenly patient collapses, and you find this tachycardia and sweating and progressively rapidly collapsing blood pressure, and progressively hemoglobin level is falling down, and by the time you become fully aware, now where you will compress, then you will be in a big trouble. And sometimes even you have to do exploratory laparotomy. Is that right? This is one big complication. It is life-threatening complication, most horrible complication, most horrible clinical trap while you were making a simple puncture in femoral artery. Then other complications can also occur. You know, from external iliac artery, there are branches like inferior epigastric artery and deep circumflex iliac artery. These side branches, sometimes if you are making puncture too high, you might damage these vessels or lacerate these vessels. And laceration of these vessels can also lead to hemorrhage. Laceration of these vessels can also lead to hemorrhage, and again there is nothing to press against, right? Then we can come to that because vein is going along with it. Which vein should be here? External iliac vein, and here it converts into this is saphenous vein draining into. Now, which vein is this? External iliac vein. Sometimes what happens, if it is too high, right, and you are doing it blindly, you might pass the needle through and through, transfix these two vessels, right? And that might make a, yes, if needle passes like this, right, that will make a very dangerous thing, and that is when you pull the needle back. This is high pressure system, arterial system, this is low pressure system. This will not close. This hole of transfixation of these two vessels will not close because high pressure will move towards low pressure, and blood will start moving from arterial side to venous side. We call it iatrogenic arteriovenous fistula, right? So iatrogenic arteriovenous fistula can also be made. But remember, this fistula is more common here. This is more common here. But it can be made there, it can be made there, even at too low veins are there, it can also be made there. Then there can be laceration of vessels. Another very important thing, which most of the doctors don't remember, because good doctors remember that if too high, the biggest catastrophic complication is retroperitoneal hemorrhage, right? But if side vessels are damaged and slow bleeding is occurring and hematoma is being formed, retroperitoneal, if this goes under the fascia of iliaca, iliopsoas fascia, you know, the muscles on the back of pelvis, there is iliacus and there is psoas coming, right? From spine, psoas is coming, and from iliac fossa, iliacus is coming. And they are having iliacus fascia or iliopsoas fascia. Now what happens? That I will make the muscles. This is iliac muscle and here is psoas muscle, right? Now this is the spine. This is the spine. Now, and so iliacus and psoas, below they become come together, so we say iliopsoas. They are having you can say fascia in front of them, anterior to them, and this fascia is called iliopsoas fascia. This fascia which is interior to these two muscles is iliopsoas fascia. Sometimes bleeding occur behind the iliopsoas fascia, which is very tightly plastered with the muscles. So that bleeding will be under, that hematoma will be under high pressure. And then you know your beautiful nerve. Which nerve is coming here? Femoral nerve, right? From here with iliopsoas it will come down, and here you see this is femoral nerve, and this here it is on iliacus, and when it crosses the inguinal ligament, here it is coming into triangle, femoral triangle. Now this nerve is just interior to the muscles but behind the iliacus fascia. In this diagram, here is the iliacus fascia and here is the transversalis fascia, and both of them together are making, what is this? Femoral sheath. So this is iliacus fascia. So what is 2 points you have to remember. Number one, that this nerve, femoral nerve, is lateral and outside the femoral sheath, and in the pelvis, femoral nerve is between the muscles and iliopsoas fascia. Now, in that pocket, if hemorrhage occurs, if blood is accumulating here, eventually, gradually, it will start compressing the femoral nerve. This is called iliopsoas fascia compression neuropathy. Or you just remember that there is compression neuropathy, and this compression neuropathy will damage the femoral nerve. You know the result, what will happen. That femoral nerve is the main supply, motor supply to the quadriceps muscles. So patient will have trouble with the extension of the knee and difficulty in walking. And also this femoral nerve supplies the mainly cutaneous supply to the interior of the thigh, and through the saphenous nerve it supplies to the medial side of the lower leg, right? So all these you can say area which is supplied by the cutaneous component of the nerve, that also shows paresthesias, right? Then of course another finding is patellar reflex may be lost, right? So what we have discussed up to now, that number one, if puncture is too high, I will say there are three things. If puncture is too high, if it is too high, number one was retroperitoneal hemorrhage, and that can lead to shock, and even if it is not recognized at that stage, it can lead to death, unfortunately. Secondly, there may be too high lacerations of side vessels, less commonly AV fistula. I will discuss that in more detail when I discuss the two medial puncture. And then of course compressive compression femoral neuropathy. This is the most acute and serious problem, retroperitoneal hemorrhage, and this is very gradually developing chronic problem, but still it needs to be diagnosed if you want to save the patient's quadriceps. So these are if puncture is too high. Now we come to if puncture is too low. When we say that unfortunately someone has made the puncture and too low in the femoral system, femoral arterial system, two problems will occur. Number one, because common femoral artery bifurcates here. So if you puncture into superficial femoral artery, which is continuation of the common femoral, or you puncture the profunda femoris, in both cases you have problem number one, that you are puncturing smaller caliber vessel. Smaller caliber vessel. This is one issue, and I will tell you what problems will occur due to that. Second problem is that you have gone beyond the head of the femur, you have gone more inferior to the head of the femur, and behind these two vessels you don't have any bony structure which can, against which you can compress these vessels to stop the hemorrhage, right? So what happens, again I will repeat, the real problem is if puncture is too low. Which puncture is too low? That femoral arterial puncture which is below the bifurcation, right? When it is below the bifurcation, right, it will puncture the what? Number one, relatively smaller caliber arterial trees, arterial vessels, and number two, if bleeding is there, if you compress it, it will softly go back. There's no hard bone behind it against which you can press it. because we have left the head of the femur up. Is that clear? So what complications can occur over here? Number one, if it is too low, that when you pull the needle, it is small vessel, and as compared to the this area, this hole and this hole, both might be the same size, but because it is in smaller vessel but high pressure, there are more chances it will bleed. And if it will bleed, it will make hematoma. So chances of formation of subcutaneous hematoma in lower puncture is far more than the golden area puncture. This is one thing, hematoma can be formed over here. And sometimes this hematoma takes the form of pseudoaneurysm. Now I need to explain you well what is normal aneurysm and what is, of course, aneurysm is not normal, but what is aneurysm and what is pseudoaneurysm. So one complication can be below that, that is pseudoaneurysm. Let me tell you. First of all, I define aneurysm. Aneurysm is pathological dilation of blood vessel which is irreversible. Pathological permanent dilation of blood vessel which is not reversible. Sometimes blood vessels, if you give vasodilator and vessels dilate, later on it will go to normal caliber. That is not aneurysm. Aneurysm is what? Aneurysm is usually there is some structural defect in the wall of the vessel, and due to high pressure in the artery, that stretches out or balloons out either full circumference or a part of a circumference of the arterial wall. It pouches out and it is not reversible, right? That is aneurysm. The beauty of aneurysm is that blood is still in the cardiovascular system. It is not leaking out in an aneurysm. Even though aneurysm have a high tendency to rupture, but until they don't rupture, the blood is still confined in the cardiovascular system, right? But pseudoaneurysm is that, let's suppose you puncture here, right? You make a puncture here and blood start coming out. This is profunda vessel. Or you puncture here and blood start leaking out. Now, because it is high pressure system and this puncture did not close, and of course you cannot close it by a simple mechanical compression or manual compression because they don't have back support or bony support. So when blood is coming out, not only this, they make hematoma, that hematoma, for example, this black, I'm showing the blood. Of course, normally blood is not black. This is accumulation of blood. Now this blood is accumulating in surrounding soft tissue, right? This blood is being pushed out of the blood vessel, making a swelling which is full of blood, but its wall is not made, its all walls are not made by the wall of vessel. Rather, soft tissue is making, or surrounding tissue is making a significant part of this aneurysm. Such aneurysm is not true aneurysm. This is called pseudoaneurysm. So what is pseudoaneurysm? Pseudoaneurysm is when an arterial vessel start leaking into surrounding tissue and hematoma is formed, and most of the walls surrounding the hematoma are made of the surrounding tissue, right? And usually this might be pulsatile because with every pulse more blood is coming and it is pulsatile. So it is a pseudoaneurysm might be a enclosed pulsatile hematoma which is on one end communicating with arterial lumen, other end it is making a blood mass in the soft tissue. So pseudoaneurysm is one more complication if you puncture too low, right? Then veins. Here, femoral artery has clear-cut vein, but in between because there is, what is this? Sheath. This is femoral sheath. Now, between common femoral artery and common femoral vein, there is septum of femoral sheath. If you come over here, you look, this is femoral sheath, right? Femoral artery, common femoral artery, golden segment, and vein, associated vein, and there is septum in between, right? Even you can look here, right? The septum is there. But there is a problem. By the time bifurcation occurs, femoral sheath is terminated. Femoral sheath was coming, gliding down, enveloping the femoral artery and vein, and also lymphatic system with lymph nodes and femoral canal, which is most medial component. But it terminates around this area before the bifurcation. So if you have gone too low, you will puncture, right? But femoral sheath is no more there, right? And because femoral sheath is not there, then associated veins are just wrapping around the arteries. Associated veins, for example, this vein, what is this vein? Superficial femoral vein or profunda vein, that is just very much an intimate relationship with the arterial system. Actually, it is true. As you move to smaller arteries, the veins become too much intimate, right? But if you go to the bigger artery, vein and artery are side by side, but they are a little bit having some connective tissue in between, significant connective tissue. Because these veins are, if you make too low a puncture, because these veins are very much physically attached or sometimes wrapping the arteries, profunda femoral artery or common femoral artery, superficial femoral artery. So when you needle it in the artery system, there is a very high chance the needle might pass through the arterial wall through and through and exit to and find itself into venous lumen. Here arterial lumen is too big. There are chances you hit the vein, but here in golden segment chances are less, but here chances are very high. Due to this reason, because there is no sheath over here and vessels are smaller caliber, needle will easily pass through, and then veins are more intimate with the arterial branches. So what happens? If needle goes through and through, then just when you pull out the needle, right, what will happen? Or you pull back the catheter, what will happen? That blood from the high pressure will go to the low pressure, and this will make arteriovenous fistula. I will make big detail here about this. So one of the complication here is pseudoaneurysm, that is just a hematoma which is pulsatile and its significant wall is made by the surrounding tissue, and on one end it is communicating with the lumen of the artery. Other complication is AV fistula. It produces some complications we will discuss later. Then there is one more thing which can occur there, because this is small caliber vessel, but when you are passing the sheath or catheter, right, or any tube through this, there are more chances it will damage the endothelium. The more chances it will damage the endothelium, or it might dissect the wall of artery, or even it might occlude the artery. In all these conditions, there can be serious consequences. If there is too much damage to the endothelium, that will result in thrombus formation. That will occlude the vessel, right? Or thromboembolism occur, thrombus form here and then goes to distal area into foot and digits. Number one, which have more chances to be formed in too low, puncture in smaller arterial branches. So thromboembolism can occur. Number two, what I told you, it can dissect the wall, right? If it dissects the wall, again wall injury will make it more vulnerable to thrombosis. Then, if really you have gone to smaller vessel, what will happen? That it might occlude the vessel, especially if there was some atherosclerotic plaque around and already blood flow was very low. That may produce lower limb ischemia, right? The clinical features of lower limb ischemia will occur. I will have a separate lecture on the features of limb ischemia, which is clinically presented with pain in involved area, and involved area become pale as compared to the counterpart, and distal pulses will become absent or very weak, or there may be paresthesias due to ischemia to the cutaneous blood vessels, cutaneous neuronal system, or there may be paralysis due to ischemia to the muscles and ischemia to the motor nerves, right? So what happens? Limb ischemia, clinical can present with patient complain of the pain, patient complain of the paresthesias, patient complain of the weakness, and with that, if you examine, distal pulse will be absent, and for example dorsalis pedis in this case might be absent, or posterior tibial arterial pulse might be absent, and then there can be poikilothermia. What is poikilothermia? Poikilothermia is that it is not hypothermia, it is not hyperthermia, but in cooler countries where there is you can say, or there is air conditioning going on, then this area will become very cool as compared to the other limb, counterpart limb, where blood flow is normal. Ischemic area will become cool. We say perishing with coldness, or we call it poikilothermia. Now, to be very right, exact concept of poikilothermia is that limb is unable to regulate its temperature. So limb temperature becomes equal to the temperature of the environment, right? Why? Because normally how the temperature is regulated, that if there is too much cold weather, vessels will constrict, right, and keep the internal part of the limb warm. Or if there is too much high temperature in the environment, vessels will dilate to bring more blood to the surface, so lose the heat. But in these cases, again I will repeat that if you are making a puncture too low, either you end up with the AV fistula or thrombosis or dissection or thromboembolism, or distal limb ischemia, which may clinically present with painful limb, then it may be presented with paralysis, then paresthesias, then pulselessness, right, and with that poikilothermia and pallor, right. So these are the complications which can occur in too low puncture: AV fistula, pseudoaneurysm, and limb ischemia, thrombosis, and it may lead to limb ischemia. So now we know if puncture is too high, you will have retroperitoneal hemorrhage or laceration of side vessels, or you may have compression femoral neuropathy. If it is too low, just a little repetition, vessels caliber will become very small after bifurcation, and there will be no head of the femur posterior to it to press it, right, for hemostasis. And eventually, due to these two things, number one, you have more chances to damage the endothelium, more chances to develop thromboembolic phenomenon, more chances to dissect the arterial wall, more chances to produce pseudoaneurysms, and more chances to produce AV fistulas, right. Now we come to that if there is two medial, this is artery, and if from here, if you move to medial puncture, now there are two things. Either rather than puncturing here, you have gone to medial and punctured directly into vein, or there can be that you slanted the needle in such a way that even though it enters into artery, but through the wall of artery, it goes to the vein, right? Now, let's suppose you are puncturing within this area. What is this area? Below the inguinal ligament, and still you are above the bifurcation of common femoral artery, but you drift to medial. What will happen? You will puncture the vein. When you will withdraw the blood, of course it will be not arterial blood, it will be venous blood, which will be relatively deoxygenated darker color blood. But what could be the complications here? Number one, if you go directly to the vein, this is a commonly mistake done, especially when we are trying to take arterial blood gases sample, and that sample for the arterial blood gases analysis should be taken from arterial blood from the femoral artery or radial artery, right? But if you have gone to veins, you have withdrawn the venous blood, which will look darker, and you might think it is dark because of severe hypoxia or due to cardiac failure or due to some other reason, but actually your whole report will be messed up because you have sent to the laboratory wrong sample. So venous cannulation is one problem. Secondly, if you move too medially and if you have gone through the medial wall of the artery and entered into lateral wall of the vein, what will happen? You have created, when you will withdraw from high pressure to low pressure, blood will move, right? And this movement of the blood, right, this will result into arteriovenous fistula. Now I will go into detail, because this arteriovenous fistula is very dangerous, as very big and high pressure vessel is draining into very big vein. Now you know arterial system is high pressure, venous system is low pressure. So blood, when it is coming, rather than 100% blood moves forward, a significant portion through the fistula may go to the low pressure venous system and return from here without oxygenating the limb. Secondly, pressure in the venous system will go high, and when pressure in the venous system will go high, and pressure in the arterial system will become low. If this fistula is there, in a way there is a arteriovenous shunting. Blood is bypassing a very big portion of arterial tree, right? And without passing through the capillaries, right? It is passing directly to the venous system. Now, for example, if 100 ml blood was coming here, just for an example, right? And 30 ml moves over here and 70 ml moves forward. Number one, you have lost a part of the cardiac output, right? Which has not you can say perfused the tissue. Number two, our distally arterial system become relatively low pressure system, and distally venous system become, as compared to the normal venous pressure, high pressure system. Now what happens? That, as you know, this artery is going distally, and here are what? Capillaries, and from here blood is draining back to venous system. Now, if there is shunting here, if arterial blood from here goes to here, what will happen? Here pressure is high, here pressure is low. When pressure is high, do you think blood can easily move through capillaries to the venous side? No. In the capillary system or in microcirculation, hydrostatic pressure become high, and too much fluid will leak out of microcirculation into extracellular or interstitial area, and that will lead to the limb swelling. So if there is arteriovenous fistula, there will be limb swelling distal to that, number one. Number two, here if you palpate, you may find a hematoma also. Secondly, you may find that due to high flow blood from high pressure to low pressure or high pressure to low pressure, the whatever amount of blood little bit is leaking over here, that hematoma will be producing a palpable vibration, that is called thrill. Palpable thrill will be there. Then if you auscultate this area, you will hear bruit. Some people call it brute, B-R-U-I-T, but other people say T is silent. So bruit. This bruit is produced by the, you can say, because blood is not moving in a normal laminar fashion. Rather, from here, when it immediately enters, suddenly divert into venous system, a high pressure, low pressure difference makes the velocity of the blood very high, and that produces audible turbulence. And this turbulence of blood become audible, and we say there is bruit. And this bruit will continue during systole and also during the diastole, because arterial pressure during systole and diastole in both situations is higher than venous pressure. So during systole and diastole, murmur, it is not murmur. If it is in heart, then we call it murmur. During systole and diastole, this shunting of blood or AV fistula, high flow AV fistula will produce abnormal audible sound, which is called bruit, and because it continues throughout the systole, throughout the diastole, again through the systole, again through the diastole, we call it machinery bruit. It is like a machinery murmur, machinery bruit, right? Because during systole, it will go up, but it will be continuous bruit, right? So what we found over there, due to this fistula, high grade fistula, venous system become high pressure, edema and swelling of the limb occur, local swelling might be there, and that may be producing thrill also, palpable vibrations, and if you auscultate that area, you might hear continuous bruit, right, or machinery bruit. And with that, if it becomes significant cardiac output is lost from arterial side to the venous side without perfusing the tissue, then venous return, it will develop a short circuit. Venous return to the left heart will become relatively less or more. It will become more. When venous return to the left heart become more, left heart will increase its output. For example, normally left heart cardiac output per minute is 5 liters per minute. But because 2 liters is lost here, now to maintain the perfusion throughout the body, due to this AV fistula and shunting of the blood, left heart is receiving more venous return, and it has to pump more blood. So maybe cardiac output become 7 liter or 8 liter, and eventually, so we say there is a high output going on. But despite heart is producing more than normal output, still it failed to meet the demand of the body. Then we say that patient has gone into high output cardiac failure. That I will discuss in detail in another lecture. But what happens, patient with AV fistula, right? Unfortunately, if AV fistula is large, that may result into very high venous return to the left heart, and if left heart cannot pump out all the venous return accurately, and then we say left heart has started failing, but it is failing with high output, right? So we say this is high output cardiac failure. Of course, high output cardiac failure occurs in other conditions also. For example, and sometimes in pregnancy, high output failure can occur if heart is weak. It can occur in severe anemias. It can occur in thyrotoxicosis. It can occur in Paget's disease of the bone. It can occur in beriberi, and there are many other diseases, thyrotoxicosis, in which high output cardiac failure can occur. But here we are talking about the arteriovenous fistulas can also result in high output cardiac failure. So, AV fistula, F2 medial puncture, and fistula will make a swelling which is producing a thrill, palpable thrill, or it may be producing continuous bruit, or it will be also making a swelling of the limb, and in a very advanced stage, it might lead to high output cardiac failure, right? Then we can come to another situation. If you move needle medially, I hope you never do that, but if it is going too medial, where it will go? It will end up, your needle is going from arterial, where is artery? Yes, from arterial side, it will go to the venous side, and it might sometimes, even though it happens rarely these days because we have imaging sport, it might go more medially and end up into femoral canal and damage the lymphatics, right? And then lymph start leaking out. If lymph start leaking out and that mass of the collection of the lymph, that is called lymphocele, and that lymphocele may get connected with the skin and lymph start oozing out of the body, and then we say there is lymphoria. What is this? Lymphoria. Seal, and also there can be lymphoria. But you can afford to forget that. But this thing you should never forget. Number one, AV fistula, right? And number two, formation of what is this? Yes, here also, if needle has gone medially and you have done multiple attempts, you have again damaged the wall of vein and thrombosis can occur here. Deep vein thrombosis. And this thrombus, if unfortunately, very unfortunately, if this big thrombus, which is formed into your inadvertent repeated efforts to puncture the artery, if you have damaged the vein and deep venous thrombosis occur here, and very unfortunately, if this thrombus dislodges from here, it will lead to pulmonary embolism and even death of the patient, right? So this is not a simple procedure, right? It might apparently look simple, but it can produce tragedies. There are two ways it can kill the person. Number one, if too high, retroperitoneal hemorrhage, shock because concealed hemorrhage, and death. Medially, it can slowly kill by AV fistula and high output cardiac failure, or it goes medially and produces thrombosis, and deep venous thrombosis might result into pulmonary embolism, right? So what is happening there, that venous cannulation was first complication direct, number two AV fistula, number three deep venous thrombosis, and then I told you that if you go too much medial side, then lymphocele or even lymphoria can occur, and when lymphoria is occurring, eventually this area becomes heavily infected because groin region is usually moist and there are a lot of bacteria there, right? Then we come to condition if this is too lateral puncture. If rather than puncturing here, you come laterally, what you will injure? Number one, you can injure the femoral nerve. That I have already discussed. Then what will happen? If you injure the femoral nerve, if there is direct trauma to the nerve, you will feel, not you, your patient will feel severe electric shock like pain in the leg, thigh especially, and lower part of the leg, right, due to saphenous nerve. So number one, if you directly injure it, nerve, what can happen? Immediately, there will be severe electric shock like pain, right? Number one. Number two, if you have significantly damaged the nerve, not only immediate severe pain will occur, long-term paresthesias can also occur in the distribution of cutaneous distribution of femoral nerve, that is front of the thigh and medial side of the lower leg, right? Then you can have motor complications, that all the branches which are controlling the muscles of the quadriceps, all the branches, motor branches which are coming from femoral nerve, they are basically for the quadriceps muscles. And if those muscles, nerves are damaged, nerve supply, motor nerve supply is damaged, then what will happen? Quadriceps will become weak, they become atrophied, and patient will have difficulty in extension of the knee, difficulty in walking, difficulty in standing after sitting, and of course patellar reflex will be also lost. So then another complication, if you go too lateral, sometimes you have not hit the nerve directly, but you go out of the sheath, and in this area there are small muscular branches, arterial branches which are going to the muscles. If you lacerate those with your needle, if you lacerate those muscular branches, they will start oozing the blood out, arterial blood, gradually. And eventually, a hematoma will start forming around the nerve and eventually lead to compression neuropathy. Compression, femoral neuropathy, it should remind you that if it was too high puncture, in that case also, if side vessels, smaller vessels were damaged, and if hematoma goes, you can say posterior to the iliac psoas fascia, then also that can produce compression femoral neuropathy. So compression femoral neuropathy can occur with too high puncture or too lateral puncture. And in too lateral puncture, remember, number one, direct injury, where clinical features will come immediately, especially pain and paresthesias, or it may occur gradually, because if you have lacerated the branches which are going to the muscles, you don't close them later. There's no way for you to easily know that you have lacerated, and you will try to control it. So if hematoma forms and it surrounds the vessel and compresses the, surrounds the nerve and compresses the nerve against the muscles, it may lead to eventually compression neuropathy of the femoral nerve, right? So these are the complications which can occur when you are doing common femoral nerve, what is this? Puncture. Again, it's worth remembering how to localize the femoral artery. Number one, anterior iliac spine. Number two, anterior superior iliac spine. Number 2 point, I discussed in previous lecture, pubic symphysis. And this imaginary line, the middle of it is mid-inguinal point. And just at mid-inguinal point, just below the inguinal ligament, you must be able to find what? Femoral artery. This part of the artery is called golden area for puncture or golden segment of artery. It should be below the inguinal ligament, but it should be above the bifurcation. It should be it should be inferior, you can say inferior to the inguinal ligament, but superior to bifurcation of the common femoral artery into profunda and superficial branch, and it should be anterior to the medial head of the femur. And while you are doing it, try that you go in the middle of the artery and you go relatively vertically. So you don't go sideways and don't damage medial structure, that is venous, or lateral structures that is going towards nerve, right? So here we finish our today's lecture, and in next lecture I will come to the clinicians. Next lecture I will be discussing what are different palpatory findings or auscultatory findings you can have at the common femoral artery and pick up the certain clinical clues, right? That is for the next lecture. Thank you very much.